So let's pick up where we left off on the PowerPoints, talking about now neurological alterations. So we've already talked about respiratory and we've talked about cardiovascular. A lot of this stuff is old hat to y'all because we're talking about delirium, and we've already talked about that in the pre-op
This is where I am now.
So as we discussed, these are some of the signs and symptoms that you might see of a patient who is becoming delirious, and for delayed emergence, that means just that it takes longer for the anesthesia to clear.
We can just look at ourselves for delirium.
I know.
For some of the older patients, they have what's called delayed emergence, meaning that they stay under anesthetic effects for longer than people that are younger. And what comes to mind is BUN creatinine issues, something along those lines. So your initial neurological assessment, as we talked about a little bit earlier, you're going to be in the PACU checking pupils, you're going to be checking sensation, motor ability, orientation. As we remember, hearing is the last sense to leave and it's the first sense to come back. So you need to be careful about that in your PACU conversations, okay?
Last to leave, first to come back?
Yes, last to leave and first to come back. Just because a patient opens their eyes when you speak to them, Mr. Jones, and the eyes open, that does not mean that they are aware, okay? So that's not considered to be, they're awake. You have to ask them the orientation questions. Where are you? What is your name? Where are you? What day is it? That type of thing. As I said to my students, it's a rare hospitalized patient that really knows what day it is. And sometimes when I get to the hospital at 6:45 in the morning, I always know what day it is because I'm always in the hospital on Friday. But the day thing doesn't worry me. The year thing, not being aware of the year or who's the president, is more worrisome. Okay. Delirium, as we've talked about, can be caused by multiple, polypharmacy is probably the biggest cause. Fluid or electrolyte imbalance, but you would wonder, is this a hypoxia situation? If they were oriented pre-op and they're not now, I would certainly investigate farther and not just assume that it's delirium. Post-op cognitive dysfunction naturally is more prevalent in the older population. Anxiety and depression is very common following surgery, depending a lot of times, as we talked about what the purpose for the surgery was, etc. Alcohol withdrawal delirium, we talked about how people that use drug substances and alcohol might need more anesthetic to get to sleep, and they might need more pain medication and more anti-anxiety medication to see that that's effective. But for alcohol withdrawal delirium, here comes restlessness again. I mean, restlessness is a potentially multifaceted situation, but I would assume hypoxia until proved otherwise. Insomnia from alcohol withdrawal, nightmares, irritability, and they can even have hallucinations with alcohol withdrawal. Here are some of the nursing diagnoses that can be associated with neurological post-op complications. Anybody who has received general or regional anesthesia, you need to be checking motor and sensory function, okay? That's important.
Can you repeat that?
Anybody who's had general anesthesia or regional anesthesia, including spinal and epidural, you need to be checking motor and sensory function. People who've had epidural or spinals, they're going to stay in the PACU until that has receded, because they're not going to send them up to the floor if they still have motory or sensory issues. And as we've talked about before, hypotension is a big thing that can happen when as the epidural or spinal is regressing and sensation is starting to come back, you'd be looking in the PACU for hypotension.
What are you going to do when that happens?
You're going to put their head back down flat, you're going to assess them, and they may need fluids if it's, that marked. But they're certainly not going to transfer them on up to the floor.
Right.
Where you've got 6 people to look after. Okay, so I'm drilling this in ad nauseum. Hypoxia is the most common cause of agitation. And in the PACU, safety is paramount, as it is everywhere. So here you're going to see all the side rails up probably. Did you see that yesterday in the OR? Did they have all 4 side rails up on the patient? Yeah. Okay. And all these other things listed here are just common sense, okay?
I thought 4 bed rails was restrained.
Yeah,
Except for in the
except in the
PACU and
PACU.
traveling in the hall and in the OR, you know, all down in there. As we said before, when a patient's pre-medicated in the holding area, all the side rails go up. Yeah. But you're right. I mean, in most cases it is, but not here when it's a safety situation. Okay. Now, you know, when you give Narcan, because that was, I was just thinking about that when I was thinking about restlessness and hypoxia and stuff like that. If you gave Narcan, the problem with Narcan is it does reverse respiratory depression, but it also immediately reverses pain control. So, you know, that's bad when you're administering Narcan IV and then suddenly the person can have acute pain. But better they have acute pain than stop breathing. Okay? And you're not responsible for knowing the dosage of Narcan or anything like that. I mean, that kind of stuff we're going to look up. Okay. So with delirium in the post-op patient, all this stuff, we're not going to waste our time going over this because we've already been over it with delirium in general. Okay, but safety is your paramount issue. Now with fluid and electrolyte balances, potential causes. The problems with fluid and electrolyte balance are going to be more commonly found in the first 24 to 48 hours post-op. Usually 48 hours and out, everything's kind of equilibrated, okay? But this is more of a problem in the first 24 to 48 hours, and the potential causes are listed there, which makes sense. The pre-op fasting, in my opinion, it's not the pre-op fasting that can cause the problem unless they're like diabetic and stuff. It's the days of post-op fasting if they don't advance as is normally thought to be. Like you're going to see patients
clear
on the floor.
Right.
Clear to full
Right,
fluid to...
Yeah, that aren't, and maybe because of paralytic ileus or something, they're not eating, they're not progressing from clear to full, you know, diets. And what you find, unfortunately, is that the patients are given too much time to start to eat. You know, they want to put off having to put a central line in and giving them TPN or some method of feeding them, and so they'll say, well, let's give them another 24 hours and see if things don't start to work. So one day can lead into another day. I'm sure you all have seen this in surgery units, and you'll see it this 8 weeks. And, you know, here's a person that's trying to, you know, heal a wound, etc., and they're just not really getting enough nutrition. And you see that happen quite a bit. They give them a little bit longer and a little bit longer, and the days can turn into a week before you know it. If it's something that's anticipated, like if the patient's having a GI surgery and they know that they're not going to be on a fast track to eat, they'll go ahead and put a central line in, and those people are going to start TPN right away. But it's the unexpected, a lot of times, that you're going to see it be a lingering problem for a while. And as we've talked about before, I would say all 4 of these electrolytes are ones that can be affected in surgery, but so can magnesium, which is you're going to see your magnesium, your potassium, and your calcium being the electrolytes that you're repleting the most often up on your surgical floors.
Magnesium, potassium, and calcium.
Yes, those are the ones you're going to see. And of course, they're going to be monitoring their CBC, and along with their, what do we get off a complete blood count?
Hemoglobin and hematocrit.
Hemoglobin, hematocrit, what else? White count.
With the
and
differential,
platelets.
yeah, all right, yeah.
Uh-huh.
Surgical.
Sorry, I spelled, and don't forget, platelets are the one lab value that's not on that chart, and we're going with 150 to 450,000, 150,000, 450,000.
I thought you said 400,000.
Did I say 450
It's
or
450, I thought,
It's
yeah.
450, 150 to 450. Okay, now, so as part of our fluid and electrolyte balance assessment, we're going to be maintaining strict I&O. I&O doesn't just involve what goes in through the IV PO and just comes out through the Foley bag. It also, the drainage is also going to be
The Jackson Hole.
emesis, NG tube drainage, wound drainage, and a lot of other drains you're going to see too. What's a relatively unscientific way to assess that the patient's adequately hydrated?
The turgor.
The
Their
turgor.
turgor and their, their
Yeah.
mucous membranes, how dry the mucous membranes are. Okay. Post-operative pain. This is predominantly a nursing responsibility. You're going to have orders for pain medicines, but you're the one at the bedside. So you're the one that's assessing the pain at least every 4 hours. And what do we do if it's not acceptable to the patient?
Then you
Every hour.
reassess after you give the med
Do
and
an
another.
intervention of some sort.
Right.
Okay, you either try a position change. If they're eligible for pain medicine, you give it. You get them a cool or warm compress. You do something, and you assess again within an hour, and you document that assessment. Yes.
My sister was in the hospital on Sunday.
Oh.
With an appendectomy
Oh.
she ended up having. When she got out of surgery, she went up to the floor. It was like 3 o'clock in the afternoon. And I was with her until 6 o'clock the following morning. With literally 4 different nurses. Not one of them asked her to rate her pain. The whole time I was there.
Not good.
Yeah.
Yeah. What did she have did she have a PCA pump?
No, she had, they were giving her morphine.
IV? They just gave it
IV.
without asking?
No one asked her one thing. So actually what ended up happening was a nurse caught an attitude with me because I was laying in the bed with her because you don't smell at night. She said it's against hospital policy. What if I came in and tried to give you whatever? I said, well, you could use 2 patient identifiers, couldn't you?
Oh no, you didn't. Oh, good girl. No pain meds for
The
you.
whole night, no one ever asked her her name, nothing.
Was she getting morphine IV push?
It was IV push.
Well, I
yeah.
hope when the nurse came to look and you didn't have a,
And that's what I
yeah.
said. And
It wouldn't just jab you
And I
with
said,
the
well, it's
needle.
also funny that no one's cared what her pain scale is all night. You know?
And what'd she say about that?
She was just like,
Uh-huh.
because the lady that said that to me was not the one giving her pain medicine all night. And I'm like, please.
Well, the one
Don't
thing
get
I'll
mad.
say in their favor, that they were regularly giving her
Right.
or
But
offering
they
her
really
pain medicine.
weren't. I mean, she was like
You had
begging
to
for it.
Yeah, well, that's
Before.
not appropriate,
The
as you
hospital.
know. That's not appropriate.
There was
yeah.
only 2 nurses on the floor.
What hospital was this?
St. Mary's.
St.
Oh,
Mary's.
dear, okay.
She had the,
Well, we don't have to tell the story.
oh, never mind.
I know.
Yeah, there was only 2 nurses on the floor.
Well, see, and that's
Yeah,
probably,
it was crazy.
yeah.
I learned more as a helper of my sister and the other 3 patients I helped that night
Yeah.
than I have ever in my whole nursing
Well, you know, you
career.
have to feel for somebody who's
Yeah.
one of 2 given all that care, but that's really scary. Yeah, and
Yeah.
unfortunately it happens. As we talked about before, it's very important not only to ask them to rate the pain, but to find out specifically where is the pain. Remember we talked about getting them morphine for gas pain or getting them morphine for DVT pain. Kim, did you have a question?
Yeah, I do. Let me ask you this.
Yes.
I have a friend who she's kind of she's trying to be diagnosed. She's been in the hospital now. It's been for at least a month. Well, in and out. Like she was in for maybe 7 days out, 2 days back in, 7 days out. So, you know, she's out now. She's had 3 colonoscopies. Some sort of IBS, something. She looks like she's 6 months pregnant. She's been on pain meds. But what they're doing is while she's in the hospital, nonstop when she's out. So, okay, so now she's out, but this time long enough for her to come off really good the withdrawals. And she's very uncomfortable. What do you do about that?
They sent her home with no pain medicine?
Exactly. And her doctor said, her doctor said, I didn't give it to you. Well, the doctor on call,
Yeah.
the very first night she was in, gave it to her ever since then. When she went back, more Dilaudid.
I would have thought they would have sent her out on something in a tapering
Well, she
type
said
of
that, and she's a social worker, so
Yeah.
she talked to them about it, and she,
Did we
anyway,
both
she
say that?
ended up seeing a doctor who works with, withdrawals.
Yeah.
And he says he's a big problem there, but, he's like one of 5 people that can get this medication, but, anyway, but.
Is he helping her?
He's helping her, but now she's gotta stop taking that, because she's gotta go back, they're talking about removing her colon.
Oh my goodness.
I mean, and going for third opinion, this is crazy.
That's terrible. But it is, I mean, I understand the worry of the prescribing doctor giving somebody the long term, but you
she
can't
is in
just,
pain, like,
yeah.
I mean, it clearly, I mean, she weighs 80 pounds and her stomach is up to here.
Wow.
I mean,
Wow.
she looks awful.
That's terrible. A pain specialist would probably
Yeah.
also be of help, yeah.
What was the example you were giving of morphine? So when
Well,
you
I
were
was
talking
just
about
saying,
where
let's-
is the pain
yes.
located,
Well,
and
let's say the patient, it's not incisional pain, and you're just assuming it is, it's because the valve's starting to move, it's gas.
okay, so right,
And then
okay,
you're giving them morphine, and that's just
it's gonna
slow that
constipate them,
down
right? Okay,
constantly.
thanks.
Or the other example was calf pain, like a DVT, score.
Okay,
medication.
which you would need to further assess, right?
But it is proven that well-managed postoperative pain leads to improved postoperative outcomes. We already talked about the person with the large abdominal, thoracic incision who's not willing to move and get around and ends up with a pneumonia. Okay, there's an example. Opioids are generally needed for the first 24 to 48 hours post-op. It's much more effective to give the pain med at a regular interval rather than waiting until, whose patient was that? Yes. It's totally out of control, and then you're playing catch-up. And one of the most important nursing measures to facilitating early ambulation and therefore the prevention of a lot of post-op complications is medicate the patient before it's time for them to get out of the bed. So if they have a PCA pump, recommend that they dose themselves because we're not pushing the PCA pump. If they have IV morphine ordered, give it to them about 30 minutes or so before you plan to ambulate, but of course be very careful with getting them out of the bed to make sure they're not going to have, bottom out on you. PO pain med, I would give, 45 minutes, about 45 minutes before I was going to walk them. That's the single most important nursing intervention to facilitate early ambulation, because if the person gets out of bed that first time and is in excruciating agony, they're going to be a lot
They're
less
not,
likely to
no.
get out the next time. Did you have a question, Clay?
At what point do you consider it appropriate for ambulation?
Well, a lot of times that's the doctor's order, but in most case scenarios, they're up ambulating the night of surgery if they're an inpatient. Yeah, they don't wait around. There are exceptions. Yeah. Yes.
Over the weekend, I went to the hospital with a friend's mom who had a bowel obstruction.
Mm-hmm.
And I had a question about, because I know that we're supposed to go by the patient's pain rate. And I trust her judgment, but I think she was like high as a kite. And she kept saying 10, 10, 10. And I know she's not a drug seeker or anything like that. But it was getting to the point that I was like, I think she's okay. Because I feel like she was just saying numbers after a while. Like, what gets to the point that, as a nurse, you can say, I think they're okay, and they just don't realize what they're saying at this point?
Okay, but you made a point about that. It's not up to us.
Yeah, it's the subjective. But if you know that, like this person
Right.
personally, as a
I know them
nurse, we don't
personally.
know the patients
Right.
personally, so we really can't, So if I was in that situation as a nurse, not a friend, and
Right.
that was happening, and I had been giving the patient the maximum amount of pain medicine that I can, and it's still a 10 and it's still unacceptable, that's when I call the doctor.
Doctor,
Right.
yeah,
And she was-
absolutely.
She kept falling asleep.
Yeah.
Like, she was really out
But
of it.
people can still sleep and have bad pain.
Okay.
It's
Exactly.
Yes.
Chronic pain.
Yeah, Monica?
Another orientation story. I had this guy who complained of pain at a 10. He said his headache was a 10. And I was like, okay. He was like, yeah, my headache and my lower back is a 10. And I'm like, okay. So I asked the nurse, and she said, well, go ahead, if it's 10, give him the max dose. So I gave him the max dose of Dilaudid. I can't remember what it was. It was the max dose of Dilaudid. And then, like, an hour later, he called out and he says, I'm still in so much pain. Like, can I have that pain medicine? I ran by. I was like, I just gave him the max dose an hour ago, but he has an order for every hour. He can have this certain dose if necessary. And she said, well, if the doctor ordered it and he's saying he's in a lot of pain, go ahead and give it. So I went ahead and pulled it up and gave him the next dose. So then Care Partner was doing vitals, and I was just like, can you just go peek in on him, because I haven't heard from him in like 10 minutes or so, and he's due for vitals anyway. So she was in there, and she comes back, and she's like, Monica, something's wrong with him. And I go in there, and he's sitting like this, with his dentures hanging down, and barely breathing. His post ops, I think it read, it was either
I'm not
34
there
or
yet.
43.
I don't know. I don't think
So we had to call
we're on this one.
MRT, which was right before you called the code, and Narcan him. And then he came back and he's like, can I have something for pain?
Oh my God. Well, he probably needed it with the Narcan.
Yeah. I know, but I'm just like, oh my, you realize you were
Well, you
just
know,
like,
what
oh,
I would
dang.
ask, what I would ask a patient in that situation is I would say, when I gave you this medicine an hour ago, did it touch your pain?
What happened was he had decreased liver function.
He had
And I
decreased
didn't
liver
liver
function,
fully
yeah.
understand
So he wasn't
that,
metabolizing
that
it.
wasn't going to help him as much as I thought it would.
Because if he said that medication that you gave me an hour ago did not even relieve and touch my pain, I wouldn't give him the same medicine again. I'd call the doctor and get something different. Just a minute.
Now, if you know that a patient, I know that everything is subjective when it comes to pain. But if you really have a gut feeling that this person is drug seeking, it's not our place to not give it to them if it's a doctor's order. So what do you do in that case?
Well, in that case, I certainly don't do what Monica brought up where the woman said, I need you to really push it fast or something, you know what I
Right.
mean? I would never do that. But, I mean, I would administer the pain medicine and at the same time have a conversation with the ordering doctor and tell him what you think. In MCV, you have the pain service that can come up, and we had a patient 2 8-week sessions ago, a young boy who was taking he had a small bowel obstruction. He was taking the maximum medicine. Nothing was touching him. And so the pain team came. And, I mean, I have to give it to those people. I mean, they take it seriously. They do not poo-poo and think, well, they're drug seeking. And they changed his complete regimen. They took him off what he was on, and they put him on something completely different. So you need to call in help, you know, that's very familiar with the different options.
Was it
He
effective?
had Crohn's, which is painful.
Very painful.
And, I mean, he literally, every 2 hours on the dot, he told us to write the time that we gave him the medicine
Yeah.
on the whiteboard.
But it's still not for you to say, I'm not going to
No,
break
and
it.
I understand that, but I'm saying, but if you know if this person, I mean, he'll be in the shower,
Yeah.
and he's like, oh, it's time for my blood.
I would discuss it with the doctor.
You
And
know,
make
so-
sure the doctor's aware of how often you're giving him and how the patient appears. Yeah.
We had another patient that was, she had cancer.
That's what Tom always said. He's like, you know, it's better to give it.
Like, she got labeled as a pain symptom.
Yeah.
And she got labeled as a difficult patient.
Yeah. And that's what can
And
happen.
I took care of her several times, and I really liked her. Like, she was nice as long as her pain was under control. When she was in a lot of pain, you could just see her, like, she was trembling.
Yeah.
She's like, you know, talking like, you really need something, you know, she's like that. So somehow she got labeled as difficult, I guess, because they
And
weren't
that's what
controlling her
happens,
pain.
sadly. And that's that's really unfortunate.
She went downstairs and had a procedure, and I can't remember exactly what they did. I guess they took some of the tumor out, but they gave her a fentanyl epidural. And she was up walking around and talking, and she was just the nicest person.
And there was
It's like,
adequate
because
pain
her
control.
was
Exactly. And that's what we need to, we want to err on the side of suspecting that as opposed to the other. Okay? All right. And there also, you know, is in addition to pharmacological, there are non-pharmacological. I mean, I can't tell you the number of patients who, you know, this isn't pain, but nausea, a cold washcloth over the forehead can work wonders, okay? So we always want to remember these interventions as well. Now, as I told you in, I guess it was pre or intra-op, we were going to talk a little bit about that WHO analgesic ladder, that you see evidence of this on your Cardex with patients at the hospital. If their pain's between this level and this level, they get this medicine. Between this level and this level, they get that. So these are guidelines for choosing appropriate pain med based on the patient's level of pain. So the theory is you don't start with the weakest drug if they're having a high level of pain. You know, because our object is to get it under control as quickly as possible. So this is these are general. You might see variations in these on your orders in the hospital on the Cardex. Usually level 1 pain is described as levels 1 through 3 using that 10-scale pain, and it's recommended to use non-opioids. Who can give me an example of a non-opioid?
Acetaminophen.
Tylenol, acetaminophen,
Ibuprofen.
that type of thing. Aspirin.
Well, depending, I take that back.
No, well, sometimes, I mean,
It
aspirin
can,
is
but it's a blood
non-steroid.
thinner, yeah.
It is a non-steroid.
Right.
Okay. Level 2, 4 to
Oh,
6.
fine.
We use weak opioids alone or in combination with an adjunctive medicine, meaning a potentiating medication. Examples of this might be hydrocodone, codeine. If you mix hydrocodone with an adjunct, you might end up with Lortab, Vicodin, something along those lines.
Like Percocet too.
Percocet.
Yeah.
Mm-hmm.
And won't Phenergan also potentiate the?
Phenergan, we used to give Phenergan Demerol mixed together, yeah, that's a potentiator too. And then level 3 pain, 7 to 10, we're going to go with more of a strong opioid, like morphine, hydromorphone, okay, or fentanyl.
Which category would Percocet go in?
Percocet would probably be
The second
2.
one.
2?
Yeah.
And I remember you gave us the list earlier of the meds that were weak to strong and everything. Do we need to compare that with this chart to know which meds we would give for which pain levels?
It would probably be a good idea, yeah.
Okay.
Okay.
Morphine, hydromorphone,
All right,
and what?
let's talk a little bit more about opioids. As we said before, opioids are necessary 24 to 48 hours after surgical procedures. And of course, it depends on the surgical procedure as to, you know, if it is or not. I mean, like if you have a, something really minor, you're not going to need opioids for 24 to 48 hours. But it's better to administer around the clock, monitor pain type and location, and vital signs, okay? And this we've already been over, and that's become common sense. Okay, the gold standard for the opioid, as we talked about before, is morphine, okay? Codeine is considered a short-acting or weak opioid. Dilaudid is 8 times more potent than morphine. So a lot of times morphine is your standard, so you measure everything else compared to how strong morphine is. So Dilaudid, that tells you how strong Dilaudid is.
How much did you say?
8 times.
Are you
8
taking
times.
Dilaudid right now?
That was great. Sorry.
And fentanyl is often used for chronic pain management, you'll see. Okay. What did we talk about with Demerol? You're going to see a lot of Demerol used? Probably not. Where might you see it used? You remember there was one situation, and you may see it in other places, to shivering. If the patient's shivering a lot post-operatively, and it's elevating their metabolic rate, and they can't get them to stop, you might see Demerol being used for that. But it's got seizure potential. And I read somewhere, you're not responsible for knowing this, but if it is used, it's restricted to a 48-hour period, and patients do not get more than 600 milligrams of Demerol in 24 hours. You're not responsible for memorizing that, just to give it for interest's sake. Okay, opioid side effects. We've already talked about a lot of these. One thing that's not up there would be confusion. You know, people have mental confusion and alterations in consciousness with opioids. They can. Remember we talked about pruritus, itchy skin? That's not considered to be a true drug allergy. And a lot of times patients receive an opioid despite the fact that they itch a lot, and they might get Benadryl in addition to that.
I thought we read that the Benadryl, it wasn't like a histamine reaction, so the Benadryl didn't work.
It helps sometimes, and sometimes they'll even give an H2 antagonist like ranitidine too. But I've seen them get Demerol when they're getting the opioid. I mean, not Demerol.
No more candy for you.
Diphenhydramine, Benadryl, sorry.
Right.
It might be also that they get that because it helps them be sleepy and notice the itchiness less with sedation. Yeah. Okay, so fortunately, a lot of patients have PCA pumps post-operatively, which makes their life easier and ours easier as well. Okay, and typically you can see morphine, fentanyl, and hydromorphone. We have demand only versus continuous or basal rate. And most of the time they have both going. They'll be getting a continuous or basal rate, and then they'll be able to dose themselves on top of that. So therefore, if they fall asleep and they're not dosing themselves, they're still getting some pain medicine in the system. Okay? PCA by proxy is not recommended. So in other words, we're not supposed to be pushing the button. The family member's not supposed to be pushing the button. It's fine to remind the patient to push the button. You know, Mr. Jones, we're going to try to walk around the hallway in a few minutes. It'd probably be a good idea to give yourself some pain medicine, okay? And when we change bags on the PCA pump, when we make adjustments in the rate, this is a 2 RN situation, okay? It's something that's checked. When the PCA pump is DC'd, somebody ran into this already this 8 weeks, and they order a PO pain medicine, it's best to go ahead and give them the PO medicine before you take the PCA pump down. Because it takes a little while for that PO med to get into the bloodstream. And you all may have seen this, when the PCA is discontinued, all of that pain med that's left in the bag has to be measured out and dosage things, and you have to get a witness to sign that you've wasted that much narcotic. So you want to teach the patient with the PCA to report side effects such as dizziness, nausea, vomiting, inability to void, and we're going to be monitoring vital signs, sedation level, and pain level per agency protocol. It's different in different agencies. I gave you all that example of the PCA documentation that's been used at VCU Hospital. Do not have to memorize that. It's just good to refer to. They use that RAS scale, and that way you'll know what that's talking about. So that's just for, just not for memorization or anything. We've mentioned a little bit about epidural analgesia, oftentimes used for acute post-op pain control. Here come our high-risk people. Thoracic, there's listed orthopedic, also and abdominal surgeries. If they have a pre-existing respiratory condition that you think is going to make them more prone to respiratory complications post-op, and obesity. These are the patients that have high risk for respiratory complications, okay? And particularly with thoracic, orthopedic, and abdominal, it's going to be open incisions. Laparoscopic, usually not as painful, usually with the open, okay? Epidurals can have a narcotic, opioid analgesia alone, or it can also have a local anesthetic mixed together with the PCA pump. Okay, epidurals are usually administered via PCA pump. Now, sometimes you'll have a patient who has, we'll talk about this in the mobility unit, and you all might see this up on Michelle's floor too, you may have already seen it. They'll be dosed with pain medicine into the epidural area before they come up to the floor, but they don't have an indwelling catheter, and that's like a long-acting narcotic, and we're going to talk about that more in mobility. But this is more in reference to people that have the actual indwelling epidural catheter up on the floor. They should have a sign posted above their bed that they have an epidural catheter. I'm not sure if this is true at Henrico Doctors. At VCU, nurses do not manipulate epidural PCAs. The pain team handles all of that. They come up, they adjust dosages, etc., and they check on the patient relatively frequently. It's managed by the pain team. You're going to have preservative-free morphine. You can have Dilaudid or fentanyl. Monica was talking about the patient with the fentanyl epidural. When it's given along with a local anesthetic, the sensory and motor nerves can be affected. That's why you see on your PCA sheet, it talks about like level of sensation and mobility. So naturally, safety is going to be an issue with these patients that have the anesthetic involved as well. So potential complications, we've already talked about the epidural catheter. It has that clear opsite dressing on it, and you're going to be very concerned about the leakage of fluid under that dressing or from out of that dressing. Could be the pain medicines not getting to the right place, and what else could it be? CSF, cerebral spinal fluid. Respiratory depression is the biggest concern, as it is with any kind of opioid administration. But when it's going into the epidural space, there's a higher likelihood of respiratory depression. So you need to know that's your #1 issue. They also can have sedation, the itchiness, nausea, vomiting, everything else that we talked about, and then the lower motor weakness if they have the anesthetic in there. Now when we talk about non-opioids, Tylenol and non-steroidal anti-inflammatories, the non-steroidal anti-inflammatories are listed. Aspirin is a non-steroidal anti-inflammatory, although most of the time with hospitalized patients, you see aspirin being given for what purpose? cardiac
Cardiac,
effectiveness, yeah. To
Low
protect
dose,
against
right.
to protect against cardiac and strokes, that type of thing. Not really using aspirin for pain control, usually seeing more of maybe Toradol, which can be given in a IV or IM or
That's
PO.
what you gave,
Yeah.
right?
Yeah. Didn't do anything, but you gave it. Yeah.
Oh, it didn't do anything?
She had to get
Didn't
dilaudid
touch
after
it,
that,
no.
yeah.
And then, of course, naproxen is a higher dose anti-inflammatory
That stuff
along the
doesn't
same
work for me.
family as Advil, Motrin, that type of thing, okay? And I'm going to be in a minute making a distinction between these non-steroidals here and the only remaining COX-2 inhibitor on the market, which is Celebrex.
Celebrex.
That's the only one. We're going to talk about the difference between those two medicines. Okay. Let's talk about Tylenol or acetaminophen first. First of all, this is a typo. I want you to change 1,000 milligrams per day to 4,000. That's the maximum dose for short-term use. So, the beauty of Tylenol is that it does not affect platelet aggregation, so you do not have to worry about bleeding. It also does not affect the GI system, so it doesn't give you that GI lining irritation that non-steroidals do. It is hepatotoxic and renal toxic. Now, the non-steroidals, which was the aspirin, the ibuprofen, the Toradol, and what was the other ones on there? Naproxen. They are very effective anti-inflammatories, a lot of times a lot more effective than Tylenol is, because they inhibit the release of prostaglandins. And prostaglandins are fatty acid substances that are found throughout the body. I mean, you know, women with menstrual cramps, most women find much more effect from a non-steroidal for menstrual cramps than they do with Tylenol, because it prevents prostaglandin release. But, on the other hand, it prevents platelet aggregation, so you're going to have more likelihood of bleeding. It can cause GI disturbances. Now, your basic non-steroidals that were listed there, including aspirin, they block COX-1 and COX-2 enzymes. COX-1 enzymes are responsible for gastric and renal consequences, and COX-2 for inflammation and prostaglandin release. So you can imagine how theoretically, if you could only be a COX-2 inhibitor, you would do away with the inflammation and the pain and the prostaglandin release, but you wouldn't upset the stomach.
Right,
Okay?
right.
So that was the theory behind inventing COX-2 inhibitors. But what have they found out is the problem with COX-2 inhibitors? Why have so many Vioxx? Why was that taken off the
Heart,
market?
weren't they heart
Cardiac
issues? Cardiac, yeah.
And don't ask me how that happens, because I do
So
not know.
COX-2 inhibitors.
But they found to be dangerous for cardiac. So the only one left on the market is Celebrex, and I don't know how much longer that's going to be around either. But that's the only one. So, to reiterate, a COX-2 inhibitor does not cause problems with gastric irritation. It does block prostaglandin release. So you get pain control with the COX-2, but you don't have to worry about gastric ulcers, you know, gastric lining upset. So nowadays, it seems like most of the people who get prescribed Celebrex are those that can't tolerate. I mean, they're not jumping right ahead to giving them a script for Celebrex. They're trying them on the others first. If they have a history of gastric ulcer, something like that, they might get Celebrex. So it's a very important concept to realize that with non-steroidals, we do have the platelet aggregation issue. So what labs are you interested in checking on your patient before you're giving them non-steroidal anti-inflammatories?
Your
Platelet
platelet
count, and I look at their
and your
hemoglobin and
yeah.
hematocrit too, just to make sure we're not starting out at a really, really low point.
Would you care at all about their PT or?
Not really.
Okay.
I mean, unless it was severely elevated, probably not. Yeah.
Could you repeat the last again?
I look at the platelet count, and I look at the hemoglobin and hematocrit. The exact same thing that I'm going to tell you all to look for Lovenox. Yes.
We're starting them on
For giving them a
For
dose of
NSAIDs.
non-steroidals.
NSAIDs, yeah.
Not worried about that with Tylenol. I mean, if they
Right.
have horrible BUN and creatinine and horrible AST,
You're not
ALT,
giving
I'm not
them.
worried about Tylenol.
Right.
But Vioxx, you said, was a cost
It was a
It was a
cost
cost
too,
and
too.
it was
it's off the
all,
market.
and it
They've
was
taken
like
it off.
wonderful. So many people were so devastated when
And
it
then
was
people
taken.
start dying.
Yeah.
So I don't know what's gonna end up happening with Celebrex because I think it's got increased cardiac risk too. So I don't know how much longer that's gonna be around. But complementary and alternative medicine, we're abbreviated CAM, we've already talked about a lot of these, options. Interestingly, some people do consider physical therapy and occupational therapy to fall under this realm. I mean, a lot of physical therapists, you know, they use deep heat ultrasound and things like that, which can really be beneficial for pain. So a lot of times they're categorized in this type of category. TENS units, has anybody here ever used a TENS? You have used it, has it been effective for you? Good, yeah. I don't see those as much as I used to, but a lot of people get a lot of good, you know, give a little electrical stimulation to the region and can really be helpful. And then, of course, I see a lot of these things mentioned in care plans down here below, distraction, less so imagery and hypnosis, but y'all are nursing students in general are real good about bringing those up and sticking them in there to get yourself another nursing intervention. You know, I know how, but if you but distraction's the easiest thing. I don't know how I would feel if I walked into your client's room and you were putting them under hypnosis. Unless you could show me you were
show
certified
pictures.
or something. But distraction can be very effective. But image, I might be less comfortable with imagery, but distraction is very common. So I see a lot of that on the care plan. So if I see that on your care plan, I might ask you to demonstrate what you did that with your patient. But they can be very, I mean, have you seen patients that are just having a really bad day despite pain medicine, and in comes a family member and they're just a different person. So, I mean, there's distraction for you. And same goes with acupuncture, unless we have somebody who's certified in that. Magnet therapy, a lot of people have a lot of belief in magnet therapy to help. I see it used mainly for like osteoarthritis and things like that. And then herbal supplements. I think herbal supplements can be very beneficial. It's just real important that the quote-unquote traditional care provider is aware of what you're taking, okay, so that interactions can be looked up and things like that. I know glucosamine, I used to give my older dog, I would buy glucosamine at Costco, and he took that for years. And it seemed to help him at least for a certain amount of time, but that can elevate glucose. So, I mean, they're just, you know, all of these herbal supplements, like regular prescribed medications, have potential issues. So it's just important that everybody's aware of what you're taking. Are we doing okay? We're going to keep on in there. Maybe we'll get out a little bit early, but we want to keep going. Does anybody need a stretch? Everybody's okay? Yeah, Monica?
Okay, but how would magnet therapy?
How does it work?
Interfere.
Magnet therapy less so. We're talking more about herbal supplements.
Oh, okay.
And I have a friend who gets acupuncture for migraines, and it really helps. I don't think acupuncture or magnet therapy are going to interfere. I was talking mainly about the herbal supplements that are more systemic. Yeah. Okay, let's talk a little bit about hypothermia. It was mentioned in intra-op, I guess, and we talked about how we keep the OR cold and for vasoconstriction purposes and to cut down on bacterial growth. With older patients, hypothermia has more ramifications usually because they already have changes in their hypothalamic regulation and decreased levels of body fat too. But here's some of the complications that can occur. Bradycardia we talked about earlier, okay? There is shivering, which can increase O2 consumption, which you might see Demerol used for. The intraoperative Blackboard, what am I trying to say? PowerPoint talked about hypothermia as being less than 98 degrees. It's lower than that. Your 96.8 is more like it. 90, a little less than 98. A lot of people run like a 97.6 temperature, so I'd go more with 96.8. And remember we talked about, you know, if you're in the OR for hours, you're going to come out with cool extremities. I mean, that's just, but cool dry skin is associated with anesthesia. But cool moist, you'd worry more about hypovolemic shock, okay? Vital signs. Temperature, note color and temperature of skin. Passive rewarming is the patient warming themselves. That's where shivering comes in. Active rewarming would be for substantially lower temperature. Somebody with a temperature of like 97.5 is not going to get a heating blanket. It would have to be low, you know, lower, I would say below 96.8. They put a heating blanket on. And when you've got a heating blanket on, what do you have to worry about?
Hyperthermia.
Well, the skin.
The skin,
You've got
yeah.
to do very frequent skin checks, like every 15 minutes to 30 minutes. Okay. And monitor temp every 15 minutes, yeah, so you don't overheat them. But that's not going to be for a barely sub-therapeutic temperature. Like a 96.5 is not going to be put on a heating blanket. Okay. Now this is an important slide in getting a grasp of at what point in time you're concerned about temperature elevations. On post-op day 1 to 3, most people are going to have a mildly elevated temperature, and that is a result of general inflammatory response to surgery, okay? So the general rule of thumb is if your temperature is 100.4 or less, we're not going to get real worked up about it up to day 3 post-op, okay? If it's over 100.4, the first thing that's going to come to our mind is they're not using their incentive spirometer enough, they're not turn coughing and deep breathing, they're not ambulating. So we're going to get on that road. We should have already been on it. But we're going to get on that road more aggressively and promote pulmonary toiletry. When you get beyond post-op day 3, then you start getting more concerned about lower elevations in temperatures because the general inflammatory response has pretty much run its course and you're getting into more worrisome territory. So post-op day 3 and beyond, if the temperature is greater than 100, you're going to start worrying about potential infection sources. And of course the wound would be probably number 1. Lungs, urinary tract infection. I'd also think about IV sites. When you document the appearance of your IV site, I don't care. I mean, I do care what the dressing looks like, but I care what the site looks like. And now that we use clear dressings, you can see the site. So when you document on your assessment form the appearance of the IV site, what would be an appropriate documentation of the site?
No redness, no edema, no drainage.
Right. No redness.
Well approximated.
Well, it's an
Probably
IV
not
site.
for
It's
an
an
IV
IV
site.
site.
Oh, IV
not
site. Sorry, I thought you were
Yeah.
still talking about.
So no, no erythema, no swelling. You could always put no infiltrate, but
No
an infiltrate would be
infiltrate, right.
swelling. No drainage. That's appropriate documentation for what the site itself looks like. And of course, you're going to be monitoring white blood count to see if that's elevating. And there will be standing orders for a post-surgical patient at what point are they cultured for a temperature above what. Now usually what does culturing involve? What samples are you as a nurse getting? Urine, sputum, and blood. And also a chest x-ray is probably going to be ordered because more times than not it's something pulmonary in function. So that's called pan culture, like Pandora's box. Everything's cultured, okay? If the patient has a Foley catheter, what is the appropriate way to get a urine specimen from the Foley catheter?
From the line up top closest to their
Like
You
from
have to drop from the
aspiration
top,
level?
yeah.
port.
Yes,
Yeah, right.
and
Not
put
in the
it-
bag.
Not from the bag,
What's a pan culture?
okay?
What did you say, a pan culture was?
Pan culture is a term used, like, Pandora's box, everything, a pan
Urine,
culture.
sputum,
which is
right.
It just,
Sputum,
everything.
Everything, yeah.
And you said there's standing orders for that based on their temperature level or based
Usually.
on what? Okay.
Usually on if the patient spikes a temp above so-and-so, get this, that, and the
Okay.
other.
Would that include wound cultures
It can be wound too, if you see an obvious
Right.
drainage.
Their incision,
Yeah,
okay.
but a lot of times you don't. And like I said, more times than not, it's pulmonary in nature, so the chest x-ray or the sputum. Sometimes it's not easy to get a sputum culture, and sometimes you have to ET suction them to get it. Yeah,
Is stool included in that?
usually not. No.
If you want
Because, bacteria is in stool.
It's there.
Yeah. Normally, but, if they suspect C. diff or something like that, then you would get a stool specimen, but normally not, no. Okay, so we're gonna be monitoring the temperature, breath sounds, all this stuff is just common sense, okay? And, we're gonna be administering, antipyretics, for fever, and antibiotics as ordered. It's common for certain surgical patients to receive post-op antibiotics 48 to 72 hours post-op. And we see a lot of that up on our floor, on the orthopedic floor. I'm sure you'll see it, and I'm sure you see it on Ms. Hatcher's floor. Pre-operatively, though, what are those patients we usually see antibiotics ordered for? What type of
Pre-op, cardiac.
Well, if they have a murmur.
Right, if they have a murmur.
Valve surgery,
right.
and a lot of orthopedic surgeries. They do, if it's a joint replacement, something like that.
What is
Are
the,
you-
I'm sorry.
Oh, I'm sorry.
What does the A/O mean? The observe for early signs of inflammation.
Yeah,
And/or, sorry,
Yeah.
thank you.
thank you.
Ms. Perlman?
Yes.
I remember you saying why they get antibiotics for the murmur and for their teeth, but I don't remember why you said they use a valve.
Because if they have atrial fib or something like that, and you mean for the heart valves, is that what you're asking? Because blood doesn't just go straight through the valve efficiently, it sloshes around, and that's a great site for bacteria to develop in the valve, endocarditis. So the same kind of reasons as for the dental procedures. The murmur indicates a valve problem.
Okay, so do they kind of go hand in hand with each other as far as the murmur and the valve?
Yeah.
Okay.
Usually.
Okay.
Now, if a patient's had a valve replacement, they're probably also going to get the antibiotics, I would assume, okay? And then you may not hear a murmur. Sometimes you hear a click because it's a mechanical valve. But yeah, the murmurs and the valve problems go hand in hand. Yeah. One indicates the other. All right, let me just take a quick peek here and see. We're doing pretty well. Let's just get through nausea and then we'll stop for the day, okay? We'll end on that note, okay? And then when we come in tomorrow, we're going to finish up post-op, including that extra material that I handed y'all today, okay? And then if we can, we're going to move into GI. So have your GI PowerPoints just in case, okay? All right.
There's a separate GI PowerPoint listed online.
Because this
It's really
post-op
big.
material is unit 3, okay? And this post-op material,
Probably
everything
the
that we've
hernia.
been covering starting today is what's on the test
herniator.
2 weeks from today, right? Yes.
Post-op is test 2 and then GI is 3.
GI, GU.
And
is
GU is 3. That's
Yes.
after Thanksgiving.
That's
right.
correct, yes. Okay. All right, so with nausea, we talked about nausea a lot when we were talking about pre-op and even intra-op. But I read, which I'm surprised it's not higher, and every time I give you a statistic, you don't have to write it down, unless you want to make a diary of it and read it out later. But I had written 20 to 30% of post-op patients with general anesthesia develop nausea. I'm surprised it's not higher than that, but I read 20 to 30. People that are prone to nausea, the obese are, of course, those who have general anesthesia, and as we said in the pre-op, anybody that has problems with motion sickness and stuff like that is going to be more likely to have post-op nausea, vomiting. We talked, I think, what are some, besides the discomfort of nausea, vomiting, and how not being nauseated makes you feel, what are some of the other post-op complications that a patient who's nauseated and vomiting might?
Aspiration.
Aspiration,
Split fluid and electrolyte.
dehiscence and electrolyte abnormalities, What if they've had brain
Dehydration.
surgery?
Oh, intracranial
pressure.
Increased intracranial pressure, if they've had cataract removal,
That's all pressure.
increase of interocular pressure, yeah. So those are, it's not just a discomfort thing, it's more than that. And another complication that people can have postoperatively is hiccups. And can you imagine having an open abdominal incision and having violent hiccups? That would be misery. And oftentimes that's caused by irritation of the phrenic nerve during surgery, that innervates the diaphragm. And if they have a lot of gastric distension, if they have an intestinal obstruction, if they have a subphrenic abscess in the diaphragm area, those are all higher risk for developing hiccups. If they even just have an NG tube in place, that can stimulate hiccups in some people. And if they're drinking a lot of real hot or cold liquids.
What do they do for the person to get rid of that?
Well, the only thing, and I don't know if they're still using this, but they used to give Thorazine, which is that antipsychotic drug. For some reason that helps with hiccups. Yeah. But I mean, that can be miserable depending on where your incision is. Hiccups drive me crazy anyway. I mean, they make me really fatigued for some reason. But nursing interventions for nausea. Antiemetics. What were the two antiemetics we talked about?
Zofran.
Phenergan and Zofran, right? What would be an example of a prokinetic medication? Something that promotes gastric motility. Reglan. Now we don't see Reglan used as much anymore. It's got a black box warning for it's either seizure or dysrhythmia, I think. What is extra, like the jerking and stuff? Okay. But it's got a black box. Do you see it used much? Reglan?
I have not seen it at all. They used to give it to, like when my son, he had, my niece had Reglan. When she was a baby, they used to give it out to infants, and it just disappeared. And I was like,
I don't think they use it at all with children, is what Lindsay Waltney told me. But you'll occasionally see it with adults. It's not off the market, but Reglan, R-E-G-L-A-N, is a prokinetic medication.
They used to give it to promote milk production in lactating mothers.
Oh, okay. Do they still?
No, absolutely
Okay.
not.
Okay, all right.
What's Reglan for?
Of course, if somebody's nauseated, you're not going to have them
Prokinetic
lying flat in the bed.
meds,
You're going to
promotes GI
elevate the
motility.
head, and you're going to that's a good place for keeping them on their side, right? With the left side down and the right side up, because we're worried about aspiration. There's the cool cloth to the head and flat carbonated drinks. Now, as far as post-op complications, anybody that's had general anesthesia is not going to have active bowel sounds when they are in the PACU or for the first day or so post-op. They're going to start reoccurring, but it's going to take a little while. Whereas bowel sounds are a very good indicator of peristalsis, the best indicators are the passage of flatus or having a stool. That's something to get excited about. More so than active bowel sounds, okay? So the rule of thumb is after abdominal surgery, the small intestine starts to function sooner. Within 24 hours, things start moving in the small intestine, and in the large intestine within 3 to 5 days. So somebody who's had intestinal manipulation during surgery, it's going to take a little bit longer for their peristalsis to resume.
What were those times? Small intestine, what?
Small intestine 24 hours, and large intestine 3 to 5 days.
Thanks.
Uh-huh.
Does that like include like a colon infection?
Yes,
Yes,
anything that involves the colon, yeah. Or anything that involves even in the stomach, any place where your intestines have been manipulated, whether they've been cut on or moved around, to make room for something else, okay? All right, so when we're assessing bowel sounds, as you all remember from 226, we're listening before we touch, okay? We're looking for abdominal distension, and when your patient has had abdominal surgery and has an incision, that does not mean that you can't touch their stomach, okay? You're certainly not going to do deep palpation, But as part of your morning assessment, after you listen, and where are you supposed to start listening for
Right
bowel
lower,
sounds?
right lower
Right
quadrant.
lower quadrant. After you listen for bowel sounds, you should apply mild pressure around the abdomen away from the incision. That's the only way you're really going to be able to tell if they're soft or distended, unless they're blown out, you know, to kingdom come. So we're real hesitant to touch the stomach after an abdominal wound or touch anywhere around an incision, but you can do this on a gentle basis, and you need to. Okay? All right. And people that are more prone to have a prolonged paralytic ileus are those that have been under general anesthesia for a long, huge case, like a 12-hour case. We already said bowel handling, or also those that are getting a whole lot of opioid analgesia. They're going to be more at risk for long term. When you listen, what do you do? And the people in my clinical group don't need to answer because I think I went over this in clinical. When your patient has an NG tube to low wall suction and you're coming in the morning to assess their bowel sounds, what should you do before you listen? You're going to disconnect the NG tube from suction. And I don't do that because you're going to hear the suction. You're not going to hear the bowel sounds if you don't do that. And the way I do that is I don't manipulate the suction valve on the wall. I leave it like it is. I just disconnect where the suction tubing goes into the NG tube. And then, you know, you have that blue port, the air port, which we never inject anything through, okay? I loop it over and put it on the adapter, so that way, if it's draining stuff, it's not going to get out all over the patient. And I listen for bowel sounds with it off suction, because that's the only way you can really do that. When patients are on, have an NG tube, we need definitely to provide adequate mouth care because their mouth gets so dry. And you know what we're going to do? Let me see where this is. Let's just finish talking about the Salem something, and we'll finish in GI, and that's the end of it. Okay. Now this is where I wanted to just reiterate what I talked about before. If a patient has been getting, let's say, D5.5, this says D5.5 or D5W at 125 an hour is only getting 600 calories a day. So if you've got a patient post-op where they're waiting for the bowel sounds to start to function, as I was talking about before, they're not getting TPN, you know, they're not getting tube feeds or anything, an IV fluid at that rate, in any rate for that matter, is not giving them adequate nutrition. They're hydrated, but they're not getting adequate nutrition. So after 3 to 4 days, the doctor should be thinking about another option, okay? And we as nurses can remind them. You know, Mr. Jones came out of surgery 5 days ago, and he's only been getting D5W. Do you think it's time, you know, to think about putting a central line in and starting him on TPN? They might say forget it, but at least you asked, right? Okay. Now, what about in assessing a patient? Here's a picture. This came from your book. We're going to talk more about peritonitis. Well, let's just say something about peritonitis with abdominal surgery. People who develop,
Can I ask a question there real quick on that? The central line with the TPN, why not an NG tube with feedings that way? Isn't that a little less invasive than a central line?
well, but are you going to give somebody an NG tube feeding if they don't have peristalsis?
No. Right. So it needs to be TPN.
Yeah, have to be TPN.
And you were talking about IV fluid, D5W at how much?
This said D5W at 125 an hour.
Okay.
Only gives them 6. You're not responsible for that. Just an example. 600
Right.
calories a day. So that's what I find to be a real problem with, from a nutritional standpoint, with patients, that they just linger without adequate nutrition. We're going to talk more about peritonitis when we get to the GI unit.
Yeah.
But what are some of the signs and symptoms of a patient who might have developed peritonitis?
Definitely pain.
Extreme abdominal rigidity and guarding. So in other words, with your sister who developed the appendicitis this weekend, did she, can you tell us a little bit about her symptoms?
It was weird. We were actually at the movies Saturday night, and she was perfectly fine. I dropped her off at 12:30, and at 3 o'clock in the morning, like, she was, like, bent over about to die. She thought, because she also has polycystic ovarian
Okay.
disorder, whatever it is. So she thought it was something with
That's
that.
ovarian,
It was
yeah.
far down. And they were giving her Dilaudid, and it was like 30 minutes after that, it would just wear right off.
And does she have her surgery done laparoscopically?
Yes.
So obviously she didn't have peritonitis, so they didn't have to open her up and
Yeah.
leave her with a drain or
It was
anything.
weird though, because they told us, she went in for surgery at 12:30 in the afternoon, and did not come out till 3:30, which is way too long for that surgery. So I don't know the surgeon never told us what happened.
What took so long, yeah. But she didn't have an open incision.
She did not.
What took so long from, you said, what time did she go to the hospital?
She went to the hospital at 3:45 in the morning.
In the
and her
morning, but she didn't have
wasn't
surgery until
12:30.
noon?
Yeah.
Did they do a helical CT scan on her?
Yeah, so what did they
CT,
do?
And then they came in with an ultrasound, and then they got a second opinion. And then
Well, a lot of times, and with I'm assuming she's about your age.
she's a year older.
Yeah, and a lot of times, with young females, it's really hard to differentiate between a right ovarian cyst rupture and appendicitis. But, if appendicitis ruptures, that's a setup for peritonitis, as is like an automobile accident that involves a lot of abdominal trauma. And it's abdominal rigidity and guarding. So I'm sure with your sister, even with the all the irritation she had in this area, the last thing she wanted somebody to do was like shake her leg or bump into her bed, and that's like somebody with peritonitis.
That is so funny because she yelled at my dad when he kept taking his chair like this and getting in the bed, and she was ready to kill him.
But that's also, yeah, that's right, because even that jarring, that's one of the signs, like you raise the patient's right leg up and you
that's what they
press
test for.
down against the leg as they try to raise it, or you just shake their right leg and it's very painful. And you don't do it just for the fun of it, it's an attempt to diagnose, but anyway. But with peritonitis, the patient doesn't even want you looking at their abdomen, much less touching. You know what I mean? It's that sensitive. And we'll talk more about peritonitis when we get to the GI. But so you're going to see not many Salem sumps at all, which is the one without the Levine tube. This is the Levine tube that doesn't have the air port, and this is a Salem sump. So this is what I'm sure y'all are all going to see. And it's this air vent has to stay open to the air. It's to this port that the suction is attached. And we don't put medicines, fluids, anything down the air port, because then the NG tube starts draining out the air port. And you're faced with, you can get these little half blue, half white things that fit on the end of the air pump, but sometimes they don't work well and you have to replace the darn NG tube. So you do not want to put anything down the air vent, okay? As part of your morning assessment, in addition to disconnecting from suction and listening for bowel sounds, what else is important for you to do with the patient with an NG tube? Placement. How is the best way to check placement?
X-ray.
Well, X-ray might be, but we're not going to be doing X-ray. You wouldn't do X-ray at the beginning of every.
You can ask Marie and do the gastric secretions.
You can do that, but the best way is listen for the whoosh. Okay. So, I will tell you, X-ray is the most definitive way, but you don't get an X-ray every 8-hour shift to check for placement, and again before you put anything down it, like medicine or irrigation. So you just draw up in your large, like irrigation syringe, Toomey syringe, maybe about 20 cc's of air. Put it into not the air vent, but the suction. Place your stethoscope in the epigastric area and just push it in there, and you hear it. Sometimes you hear it without a stethoscope. It's like a big old burp. And then you know you're in the right place. So I would do that first thing in the morning as part of my assessment, and then every time before you give anything down the NG tube. You have to reassess. NG tubes, though taped, are very likely to become dislodged, okay? So you need to, be confident before you put anything down there that it's going in the right place. Okay?
Listen before any feeding, is that what she said?
You don't see many people aspirating gastric contents and checking it. We used to do that more. This is a better way, just to do the whoosh. Now, a lot of times you'll run into situations where the patient has a very, very large NG output, and the doctor puts in an order for NG tube replacement. And that is usually done via IV fluids, usually always. So a lot of times students get kind of confused by this. But like, let's say your patient put out, on the last 8-hour shift, because you're gonna be replacing from 7 to 3, you're gonna be replacing what he put out from 11 to 7. So let's say he put out 600 mLs of gastric secretion, okay?
How much, 600?
Let's say, just say 600. And you probably, most times you have an order for replace NG output half cc for cc. So what, over 4 hours, that might be an order, okay? So if he put out 600 mLs on the last shift, and
So
forgive me for
300.
saying cc, because I'm old, it's ml. If he put out 600 mLs on the last shift and you're to replace half cc for cc, you're going to replace 300 mLs over 4 hours. So you're going to take 300 mLs and you're going to divide by 4, and that's what you plug your IV pump in. And over 4 hours, he's repleted. So you might see that, or it might say replace cc for cc, or it might say replace half cc for cc over 8 hours. You know, it depends on what the order's in. But it's simple math to do that, to figure that out. And of course, they're worrying about dehydration with output that high. That's probably somebody who's obstructed, potentially. And then we ran into it last week, and I'm sure a lot of y'all have, where you're going to be checking the residual if the patient's being tube fed through the NG tube, let's say. You have an order to check residual every maybe 4 hours and hold if more than
Right.
this amount.
400.
Okay? And then you'll have an order to flush it, so you want to make sure it stays patent. If they anticipate that patients are going to be being fed this way for long periods of time, the humane thing to do is to put a Dobhoff tube in. A Dobhoff tube is a very small diameter, much more comfortable tube that goes into the small intestine. So it's placed under fluoro. It has a weight on the bottom of it. Much less likely to get dislodged and in the wrong place. And you can't really check placement of that because it's in the small intestine. But that's better for long-term use, more comfortable than the NG tube. Okay? Does anybody have any questions about what we did? We covered a lot of material today. Okay? But hopefully it'll also be helpful with the pre and the intra. It all kind of sort of ties in together. Okay, so tomorrow we'll meet in the other room then at 12. Okay, so bring your GI PowerPoints just in case we get there. Okay? All right.
You have to work after class.
And I don't think there's
Do you think you could
and
bring me to
everybody in
class
Miss
and I'll ask
Thatcher's
Terry if she
class
could
got
take me
that
home and
sheet
teach
that
us
she
something?
needed for the computer thing?
Yes,